So localization is a process of identifying at what level the lesion is. Neurology is a very long part of the body. So you, of course, starts with the brain itself. And in the brain, you have the cortex, you have the subcortical areas, you have the deep nuclei, and then you have the brainstem. And then going down from brainstem, you have the different levels of spinal cord. You have the cervical spinal cord and thoracic and lumbar. And then there are nerve roots where it comes out. And then nerve roots join to form plexuses. And then plexuses form nerves. And then nerves go on to form neuromuscular junction. And then sometimes the muscle itself. So all of this can lead to a problem. So let's look at those a little bit. So if the only information you have that someone presents with a right leg weakness, the problem could be anywhere. The problem could be in the muscle, in the joint, in the nerve, in the tendon, and in the spinal cord, in the nerve root, plexus, spine, brain, anything, right? You add information in the history to try to start localizing. You could localize even just by age and sex of the patient. So male has certain diseases more often than female. And 43-year-old is going to have certain diseases more than someone who is 72 or less than what someone has 72 or 21 or 4. So if someone, you don't know who that someone is, then anything is possible. But as soon as you define that someone, that it is a 43-year-old male, now you already have certain hints on what might be more common in that age, in that sex of the patient. And you start thinking about, okay, what is a common reason for a right leg weakness in a 43-year-old male? So if I ask you guys, what's the answer? What is to your mind come as a common reason for a 43-year-old male presenting with right leg weakness and you don't know anything else about the right leg weakness?
Injury.
Okay, yeah. So 43-year-old are active, they're driving, they're working, they have a hard labor job, they're doing different things. So injury could be a cause of, but injury where? Injury in a muscle, injury in the tendon, joints,
lower
injury
back
to the brain,
injury.
Lower back injury. So that's a very good thought that someone who's 43-year-old male might be lifting something heavy. He popped a disc or something hit him in the back of the car and he got a spine fracture. And if injury to the lower back will likely either damage the spinal cord or the nerve roots, and that will give him a weakness in the right leg, right? Anybody else have a different thought that came to their mind as a common reason for a right leg weakness in a 43-year-old male? And you don't know when it started, how it has progressed, how bad it is. You know nothing else.
If it's a chronic history, then we can think of polio.
Embolism.
Okay, so polio is one. Embolism. Embolism where?
Embolism.
Deep vein.
Femoral
vein. Yes.
Okay, so femoral vein embolism and polio. Two other possible common explanations for a 43-year-old male.
Yeah,
Diabetes. Okay, so diabetes is a cause. So 3. Anybody wants to add a 4th one or?
Arthritis.
Okay. So question will be again that if you are calling it a weakness, then it should not, in arthritis, it's guarding, this poor effort. So it's an apparent weakness, but it's just because there's a poor effort from arthritis. So if you elicit the chief complaint well, and you know that this is weakness, then arthritis cannot be a cause, it will not cause weakness. Now, let's look at the other 3. So polio is basically a slow infection of nerve roots and nerve plexus affecting spinal cord, going up into the spinal cord. So again, it's a lower motor pattern. Diabetes can cause neuropathy. It can cause a mixed motor and sensory neuropathy. Usually starts as sensory neuropathy, but can cause mixed motor and sensory neuropathy. And diabetic can also cause a myopathy, which is called amyotrophic lateral sclerosis. No, it's called diabetic amyotrophy, sorry, not ALS, but diabetic amyotrophy is a myopathy of the diabetes that can cause muscle weakness. And then somebody mentioned a femoral vein thrombosis. And femoral vein thrombosis, again, can cause a neuropathy by decreased blood flow that can affect the blood flow of the nerves in the leg, or it can cause a myopathy by causing a venous stasis, or it can cause pain, which can cause an apparent weakness, not a true weakness. So you're already starting to making a differential and localize. So your consensus is that a 43-year-old male with a right leg weakness is most likely to be a lower motor problem, because we're dealing with plexopathies, neuropathies, we're dealing with muscle injuries, myopathies, and so on and so forth. And that is true. the most common cause overall of a leg weakness in a 43-year-old male is likely going to be a lower motor problem. But if I flip around and add one more information, and if I say that the 43-year-old male presents with an acute onset of right leg weakness, meaning that it started few minutes to a couple of hours ago. So you are in the emergency room or you're in your clinic and somebody walks in and says, our patient is, or I am not able to walk in my right leg. It's heavy for last 13 minutes. It just started, so acutely started, and I'm not able to walk. What now do you think is the most likely cause?
Stroke.
Right. So the acute onset, acute onset focal weakness, focal problem. So anything that can come from one specific area, not diffuse like delirium or confusion, but any focal problem, which is acute onset, is stroke until proven otherwise. Now, it may not still be a stroke. Now, 43 is a young age for stroke, although we're seeing young onset stroke more often because of climate and smoke and so on and so forth. But so that will be the first thing in your mind. But what other things besides stroke in a 43-year-old, because 43 don't often have strokes, would present with an acute onset of right leg weakness?
Sir, hypertension कोई role play करेगी?
Hypertension can cause hemorrhage in the brain, so that can present as a stroke. Hypertension can cause hypertensive emergency. So hypertension, elevated blood pressure, which is too high, can cause hypertensive urgency and hypertensive emergency. Hypertensive urgency is any blood pressure that is more than 180 for someone without chronic hypertension and 210 with chronic hypertension, while hypertensive emergency is someone who has any of the four problems. So one is shortness of breath, dyspnea. One is focal neurological deficit, like leg weakness or something. The third is, and it may be a reversible ischemia going on in the hypertensive emergency. Third is delirium, and there's a fourth one that I cannot recall right now. So anytime someone has a hypertensive emergency, they can present with an acute ischemic looking stroke, which is reversible. If you treat the hypertension, they might actually get better. So now,
be a neuromuscular disorder, myasthenia gravis.
So myasthenia usually do not present as acute. They will give you, it may be that the weakness started half hour ago, but they're having this weakness off and on towards the afternoon for the last 2 months or 3 months. So my neuromuscular junction problem, like myasthenia, often are subacute remitting or subacute progressive with remitting relapsing phenomena. Other things that can be acute will be inflammation, but again, it's usually subacute. So someone with MS, if they have a weakness in the leg, it usually comes on more than 24 hours. So over 2 days or 3 days ago. And by definition, it has to be for more than 24 hours before you call it as an MS attack. And then some acute presentations will be epilepsy. Post-epileptic weakness of the leg can happen. It could have been a focal epilepsy and it caused the weakness in the leg, or generalized epilepsy that caused the weakness in the leg. The other acute thing could be complex migraine. So complicated migraine or neurological migraine can present with a focal stroke-like symptoms, like hemiplegic migraine, which can also be just in one limb. So right now, every time we're resetting it. So we're just going by the information that is in that one line. So you can see how this localization happens with the history when you have the onset, trajectory, age, male, and we have not even gone to the examination. Now let's add a scenario. Let's change the scenario. And if I give you the information that 43-year-old male presents with acute onset of right lower extremity weakness, and on examination, you find that he does not have any reflexes in that leg, then what is the most likely diagnosis? Acute onset, right lower extremity weakness in a 43-year-old male, and examination is showing absent reflexes. What is the most likely cause? No other information is available. You have to decide on this information.
Neuropathy.
Neuropathy is slow onset, so it comes on gradually, progressively, whether it be diabetic or non-diabetic. Sorry?
Sir, it could be hyperkalemic periodic paralysis. It could.
So it will not be just like right leg. Hyperkalemic periodic paralysis will be generalized weakness, or at least both leg involvement.
It could be a damage to the nerve.
That's right. So it has to be something that has acutely affected the lower motor part of the system, and that will be likely traumatic. Most common we're talking about, not all exhaustive possibilities. So likely trauma and most likely trauma is usually disc herniation. So 43-year-old male who either fell or herniated his disc because of a trauma or non-traumatic, and is causing an acute compression of the spinal canal, and that is causing the right lower extremity weakness, is likely a lumbar problem, and that's why he has lower motor presentation of the lower extremity, and it's likely L4, L5 disc herniation, acute disc herniation that is causing it. Now, in most acute disc herniation, this will improve, and the reflexes may remain suppressed, but the weakness will gradually improve with exercise and therapy. But in some cases, if the disc herniation is extremely severe, then you may need a surgical correction before the weakness will improve. So a weakness in a disc herniated disc is a surgical urgency, and you want to do them priority surgery. Otherwise, if it's just pain with disc herniation, you can wait and you can do therapies and wait for things to improve. But for a weakness like this, you would likely go for it. And it could be traumatic. It could be a traumatic piercing trauma. It could be that he was stabbed in the hip, in the groin, and that injured his lumbar plexus. That could be a cause. It could be that he bled in his lumbar plexus for some other reason, or a tumor that broke or ruptured, but something has acutely affected his lower motor nerves that is causing this problem, and that's why he doesn't have reflexes. Now, let's change the scenario. And if I tell you that 43-year-old male who presents with acute onset of right lower extremity weakness, and on examination, you find increased reflexes and a positive Babinski in the right leg, what is the most likely explanation?
Upper motor neuron.
That's still a very broad area. Where exactly in upper motor neuron? Stroke where?
Left cerebral.
Why it is less likely to be left cerebral stroke? And the reason is that the lesion is very localized. So right leg, you have to think where the lesion has to be to just give a right leg weakness. It has to be in motor cortex. It has to be medial motor cortex, right? The homunculus, the leg is all the way in on the medial part of the frontal lobe. And that is an area supplied by the anterior cerebral artery, and not a common area to have a stroke isolated. Usually it's a whole MCA stroke, and then you get a diffuse weakness, arm and leg, with or without speech or other cortical function. Now, lacunar strokes in subcortical area internal capsule can give hemiplegia, but it's usually dense hemiplegia, meaning that there is significant weakness of both arm and leg. Similarly, brainstem strokes will often give you both arm and leg weakness. So a place which is more likely to only give leg weakness will be spinal cord without any arm involvement. That means it has to be a thoracic spinal cord or below C7T1, because that above that will be arm involvement too. So a C7T1 or even below that, a thoracic lesion can present with a right leg, upper motor weakness of right leg with Babinski present, and just leg involvement and sparing of the arm. Based on the description I gave, presumably the arm is normal, right? In that description, there is nothing about the arm. Now, it may be that you examine the patient and the arm is also weak, then you will move the lesion up to cervical spinal cord, or there are cranial nerve involvement, you move it up to the brainstem, or there is cross reflexes, cross abnormality, then you move it up to the internal capsule, or there's cortical signs like speech impairment, you move it up to the cortex. So you move that lesion up as other things are added on your examination or on history, but just based on the information given, the lesion right now is just at thoracic region. That is above lumbar, but below cervical. So there is no arm involvement, only leg involvement in an upper motor feature. So this kind of thinking of what is available, what available information, and putting this together is what we call localization in neurology. And it's a very simple, straightforward thing. All of you are right now localizing the lesions, and there's nothing unusual or unique or strange about it. Let me quickly show you this picture, and feel free to unmute and comment in between. Feel free to interrupt me. Otherwise, I'll keep going just the interest of time. So this is the whole neurexis, right? So you have the cortex, frontal lobe, the subcortical area. The cortex is divided into frontal, parietal, occipital, and temporal lobe. Then you have the brainstem, you have midbrain, you have pons and medulla, and you have cerebellum. And often we try to identify the lesion to one of this area. We don't say brainstem lesion, we say midbrain lesion, or we say pons lesion, or we say medulla lesion, because they are all different. And you can have hints to tell you where the lesion is. And then there is a spinal cord. And again, we just don't say spinal cord. We say cervical spinal cord or thoracic spinal cord or lumbar spinal cord. And then there is the nerve roots and plexus. And then there is the nerves themselves. And then there's the end organs, which may be somatic or autonomic end organs. And this is where we're trying to localize. Now, what is the line between, or where is the line between upper motor neuron and lower motor neuron? Where does upper motor neuron ends and lower motor neuron starts?
Cervical 7 to thoracic 1.
When they come, fibers come down through the cell cord, and from each of the interior horn cell cord, they start lower motor. Above this, there are the upper motor neurons.
Yeah, above what? What level are you describing? I missed that. By the way, in the last example or scenario, I gave you a thoracic spinal cord lesion as an explanation for upper motor neuron presentation in the lower leg, in the right leg.
You said
So where,
C7 and T1.
right. So let's look at what is called as lower motor and what is called an upper motor, so that we can then understand what is the separation between the two. So let me share you this picture. This is a picture that describes deep tendon reflex and how deep tendon reflex work. That there is sensation, sensory receptors or stretch receptors that send in information into the spinal cord. And in that spinal cord, in the gray matter, there are interneurons, and then interneurons connect them with the motor neurons in the spinal cord. And the motor neurons then come out and then they contract the muscles. If the motor neuron or the nerve root where the motor neuron is going, or the plexus, or the nerve, or the neuromuscular junction is damaged, then the motor neuron will not be able to cause the stretch reflex, right? So the deep tendon reflex will be absent if somehow the connection between the muscle and the motor neuron is broken. And that absent reflex is what we have already talked about as a lower motor presentation. Now, this motor neuron, which sits in the spinal cord, is under influence by the connections coming down from the top, from the brain running through the spinal cord above or the brainstem. And those connections, when they are suppressing this motor neuron, so motor neuron really wants to cause a big jerk. But the reason the big jerks do not happen in a normal person is because those fibers coming down from the brain are telling motor neuron, calm down, calm down. You just give a little bit of a reflex. Don't give a long reflex. But if we take them away, if we cut them, and there is no suppression coming down anymore on this motor neuron, then the natural tendency of this motor neuron, as long as it can reach down to the muscle, is to cause a big contraction. So reflex will be exaggerated. So if the motor neuron is able to connect to the muscle, there will be reflex. If not, there is no reflex. If the motor neuron is under influence from the top, then the reflex will be normal. If there is no influence from the top, it got cut somewhere, then there will be exaggerated reflex. Exaggerated reflex is the upper motor neuron, and the absent reflex is the lower motor neuron. So this motor neuron sits, the start of the motor neuron is where the transition from upper motor to lower motor happens. But where is this motor neuron? And the motor neuron is at a certain level for each muscle. For the this muscle shown here, the thigh muscles, the quadriceps muscle, the motor neuron sits at L3, L4 level in the spinal cord. But for the biceps and triceps, the motor neuron sits at the C5-6 or C3-4 level in the C4-5 level in the spinal cord. So there is a transition of upper to lower motor neuron happening throughout the spine, depending on which muscle or which limb you are talking about. So for the lower limb, the transition is complete by T12 or L1. Anything above L1 or T12 is upper motor, and anything below is lower motor. But for the upper limb, the transition is not complete, is complete above C3. So C3, C4, anything above that will be upper motor for the upper limb. Anything below that will be lower motor for the upper limb and not upper motor. So the transition is at the motor neuron level. This is the transition point for the upper motor to lower motor neuron for each of that muscle, and it goes down. So throughout the spinal cord, there is that transition happening from upper to lower, upper to lower, upper to lower for that particular muscle. So depending on which muscle. So for a right leg weakness, it could be upper motor neuron lesion for the right leg if the lesion is in thoracic cord or in the cervical cord. But for the upper limb, it cannot be upper motor unless the lesion is above the cervical C4, C3 level of the cervical cord. And then it could be C1, C2 could be upper motor neuron lesion for the upper limb, but C5, 6 will be a lower motor neuron lesion for the limb. And then, you know, anything above and below will be upper motor neuron and motor neuron. Let me stop here to see if somebody wanted to say something and I was just speaking over.
So cell bodies of the motor neurons are included in lower motor neuron.
That's right. So motor neuron bodies themselves, alpha motor neuron bodies or spinal cord motor neuron bodies themselves are part of lower motor neuron. So if you injure motor neuron bodies, above this is the upper. So what disease affect motor neuron bodies? There is a very famous disease that typically destroys the motor neuron. Actually, two diseases. One that is what somebody mentioned earlier, and one that I mentioned by mistake earlier.
One is polio.
One is polio, and the other is
amyotrophic lateral sclerosis.
Amyotrophic lateral sclerosis. So both polio and ALS.
मल्टीपल स्क्लेरोसिस कर सकती है इसमें कुछ?
मल्टीपल स्क्लेरोसिस भी कर सकती है, ट्रॉमा भी कर सकता है, इन्फेक्शंस भी कर सकती है, लेकिन I was just talking about those diseases that specifically go after motor neurons throughout the spinal cord, and those two diseases are ALS and polio, but both also affect the pathways coming down to these motor neurons. So they are mixed diseases. They are both upper and lower motor mixed. Polio has neuropathy as well as upper motor involvement, and ALS also has motor disease and lower motor pattern and upper motor involvement of pathways. So both polio and ALS present with a mixed presentation of upper and lower mixed in, but they are classically go after these motor neurons as their main target for most of the injuries at motor neuron. All right, so let me just quickly show you this list. I think we've covered it already. But a lower motor neuron lesion include the anterior horn cells, and we call that amyotrophy, nerve roots, radiculopathy, nerves, neuropathy, neuromuscular junction, which will be neuromuscular disorders like myasthenia and Lambert-Eaton, and muscle diseases like myopathy. All of this is lower motor neuron. And then the upper motor neuron is cerebral cortex, deep cortical structures, includes internal capsule, brainstem, which divided into midbrain, pons, medulla, and cerebellum, and spinal cord. So all of these lesions will be part of the upper motor neuron, and then all of the other lesions will be part of the lower motor. And these are some of the common differences between the two. And upper motor neuron lesion will reduce that inhibitory effect on the muscle stretch reflex. So it will create an increased tone, which is called spasticity. It will create increased reflexes, which is hyperreflexia, hypertonia, diffuse atrophy will happen. Mildly disuse, more of a disuse atrophy. So because they're not using their legs, slowly, gradually will start becoming thinner, and it will not cause fasciculation. It will cause Babinski sign, and it will cause some other abnormal superficial reflexes like abdominal hemisteric reflex, and so on. While a lower motor neuron lesion will take away that alpha motor neuron, so it will cause loss of tone, so hypertonia and flaccidity, hyporeflexia, loss of reflexes. It will cause direct wasting of the muscle because nerves are needed for muscles to continue to stay healthy. They feed the muscle, and it will cause fasciculation, which is basically increased muscle excitability because of loss of nerve innervation. It will not cause Babinski. Other reflexes of the skin will not be present, and it usually is more localized to one limb or one part of the limb, while upper motor are more diffuse. So these are some of the ways you can say, okay, am I dealing with the lower motor list, which is this list here, or am I dealing with the upper motor list, which is this list here?
Dr. Danish, I have a question regarding GBS. Is it an upper motor neuron lesion or a lower one?
With GBS, you mean Guillain-Barré syndrome?
Yes, I do.
So Guillain-Barré syndrome is a neuropathy. It's an acute onset, progressive, mixed sensory, usually pure motor in most of the cases, neuropathy, which gradually goes from lower limbs to upper limb. So it's an ascending paralysis, which is due to a neuropathy. It's an acute autoimmune neuropathy. So it is a lower motor pattern presentation. Now there is a GBS variant, which is very rare. It's called Miller-Fisher variant. And that variant have some upper motor involvement. So it has some cerebellar sign with ataxia. It has some Babinski, it has some reflexes, hyperreflexes, but that's a very rare variant. So it will take a really good expert to diagnose a beneficial variant of GBS.